So next we're gonna have our friend here who is amazing. She's a professor at Northwestern University. She's also the director of brain metastases. She's one of the leading experts in brain metastases as well, and does conduct a lot of research and clinical trials. And she's gonna be presenting about clinical trials and design.
Great, yeah. I have to keep it on time, so I thought I'd stay close to the podium because Peter kept it right on time. So these scientific breakthroughs are so inspirational. And when we are fortunate enough to work with great scientists like Dr. Forsythe, Dr. Boer, Dr. Glitza, all of this data that you saw today, we want to take that and we, of course, want to produce the best clinical trial that then makes that therapeutic successful. So how do we do that? It's nuanced in this field. And so I do, it's uncharted territory. Barry, this is Lewis and Clark for those of you guys who don't like history. So I always have this slide, so I apologize because I'm sure any of you who've seen me speak, I always just put things into perspective. So much of what drives, I think, the folks in this room is leptomeningeal disease is so common, yet we haven't put the same amount of emphasis in trials as we have in other also very important diseases to many of us, like glioblastoma, which is another area that I work in clinical trials, and I'm sure many of you do as well. What I do want to say here is that I'm sorry that I've been using this slide for 6 years. I have been updating it though each time, and the updates are really heartening for me because I started with this number on the right, this 154 being around like 32 when I first made this slide in 2019. And so every time I update it, it's actually a little bit of a sunshine in my day because I do think that we are moving in the right direction and we're moving towards really becoming more active in this space and understanding that there is hope, to Peter's point. So we really, before we design the studies, we need to understand the challenges so that we're poised to overcome them. The first, and really importantly and near and dear to my heart, is that there is not a validated response rate in this disease, which means the foundation that you're standing on in order to see if this drug works is a shaky one. So we need to make sure that we have that as solid as possible. It's a heterogeneous population. When we say lepto, we're actually talking about a slew of different diseases biologically. Yes, there are some overlaps in those Venn diagrams, but breast and breast subtypes, lung subtypes, melanoma, et cetera, are all different biologic diseases, and we need to reflect that in our studies. It's a fragile population, and I'll talk about how we can overcome this when we're accruing to studies, and again, endpoints are challenging. I already know I need to speed up a little, so we're going to 2-in-1 some of these challenges, and this is the response rate and validated response. So we know that diagnostics in leptomeningeal disease is challenging. Radiographic disease falls short, following clinical state falls short, and CSF cytology also falls short. I'm not going to spend time on this because this audience knows it very well. So then how do we overcome this shaky foundation of endpoints in clinical trials? We need to have endpoints that are reliable, validated, and really importantly, reproducible. So for example, cytology here on the right, when we're looking at abnormal cells, we can get a positive cytology in our patients with lepto, but is that reproducible on 2 weeks later when you're rechecking? If it's negative, is it really that the disease has gone away? Or are you getting negative cytologic results because cytology is not very reproducible or reliable? So we really need to make sure that the endpoints that we select are solid footing. So there are a lot of different platforms being developed in CSF testing. I'm not going to go into detail with all of these, but you all are familiar. We're looking at tumor cell enumeration in the CSF. We're looking at cell-free and tumoral DNA, cancer cell genomes, epigenomes, methylation profiling within the CSF, FISH testing, and of course aneuploidy. So these are all things that we are now looking at, and many of them are in the CLIA certified realm as well. I get a lot of questions on CTCs versus cell-free DNA or ctDNA. There's pros and cons for each, and it's probably a little bit beyond the scope of today's talk, but we do need to consider some of these pros and cons in what we're weighing when we're talking about following a response, particularly when we're building a trial. So, tumor cell enumeration or CTCs really allows that quantitative marker that you can solidly follow. It's reproducible and reliable, and might even allow epigenetic testing down the road to be easier. ctDNA, there often is a higher abundance of that, so that can be in some ways more sensitive. It can be more reflective of a genome-wide background, unfortunately could have other DNA contaminants. And it's the hard thing that I find when we are looking at ctDNA is, what does it really represent? So if it goes up a little, are we looking at the disease worsening? Or are we looking at the disease being impacted by treatment and cells lysing, and then we have an increase there? I think that these are all questions that we still have, but thankfully I think are answerable. So what do these diagnostics offer an endpoint that those first three I mentioned, so clinical, radiologic, and cytologic, don't offer? These offer accuracy, sensitivity, quantifiability. There's trends that you can follow. So not only can you see what's happening over time, but you might even find early progression before you see it on an MRI. We've had at least one study where in the CSF we were able to show early progression in our CTCs prior to those changes on the MRI by like 8 weeks. That was our intrathecal trastuzumab study. And then super important is reproducibility. We would never do a science experiment that's not reproducible in the lab. Why would that be any different in the clinic? I always say the clinic is my lab also, and I want reproducible results there as well. So we need to think about these as we're building studies in leptomeningeal disease. One such platform that we use consistently and that we used in a study that Dr. Brenner is going to talk about right after me is this CNSide platform. And this, essentially how this works is it's CNS tumor cell enumeration and cell-free DNA detection. So the CSF is sent via this tube called the C-Shore tube. And I think it's important, the devil's always in the details. This tube keeps the sample stable for at least 96 hours. So you can ship it overnight and you can ensure that it's going to get there intact. And it's probably longer than that, but at minimum that amount of time. The reason why I think things like that are important is because we can develop all these new tools, but if they're hard to use and hard to access, meaning if I needed to send it on dry ice and take it by a courier pigeon within 2 hours to the lab, it's not going to work. So it's got to be functionally possible for patients and clinics to actually participate. So anyways, the tube. So then you have the CSF and it goes down two different workflow pathways. The first is an antibody cocktail tumor cell isolation. So it's basically the CSF goes through the microfluidic channel and there's antibodies that then grab at that and then you can count the cells. There's also once you capture that, there's also a cell-free DNA detection workflow pathway that's basically NGS on those. And then you can also perform tests such as FISH testing on this. So it really allows for in-depth testing on the CSF and actually allows it to be done in a very practical manner. So with CNSide, we had many retrospective analyses showing utility. Prior to the 4C study that I'll show you on the next slide, we had no prospective study to date. But what we found with these retrospective studies is that CNSide helps to diagnose leptomeningeal disease, helps to determine response to LMD-directed therapy, and helps to inform specific LMD therapy selection. So we have all of these possibilities with one diagnostic tool, but there was no prospective data in a controlled setting to actually confirm this. And what we really wanted to confirm was clinical utility. Is it actually helpful in the clinic, right? That's what all of this comes down to. Is it helpful for treating our patients and in those decision makings? And so essentially, and how does it stack up to our current gold standard, namely CSF cytology? So with that, we designed the prospective 4C study. really trying to answer these three questions. Is there a tumor? Is there a target? Is there a trend? And essentially we did at concurrent time points the standard of care diagnostics as well as CNSide. So we presented this last year. I didn't go into it in too much detail here. Dr. Brenner is going to talk about its impact in the ReSPECT-LM study, but essentially we found that it was widely high patient utility in all of these situations, whether it's treatment selection, disease monitoring, and disease trending. It's really important when we are thinking about these studies that we don't just say, this is going to accrue just like this other population will accrue, namely, for example, glioblastoma, which again is another disease that many of us take care of. The logistics are impacted by the outcomes of these patients. So this is, as you guys know, this is a population that doesn't do as well. So you're going to see if their survival, let's say, is 2 to 4 months, and you are spending 2 weeks to get them on study, which is very typical for a glioblastoma study, you're going to have many patients fall off because of that. So the speed of LMD progression and patient enrollment is key. So if we are going to do more studies in the LM population, we cannot just copy and paste from what we know from primary brain tumors. We got to do it differently. We need patients to be consented, screened, and registered fast, not weeks like other studies. We need, for phase 1 dose escalation, that can be even harder because, especially for multi-center, if the study's opening and closing, you can't have a patient wait 3-4 weeks for a study. That's too long. And then ultimately for the patients who can sometimes make it through these hurdles, does that actually represent the true population? So we want the studies that we build to represent the population that we're actually going to treat once hopefully that drug is approved. All right, but all of those hurdles being said, I do, like Peter, want to end on a positive and hopeful note, which is that we got this. We have more studies in LM than we ever have. It's been really amazing to see this evolution, particularly over the past 10 to 15 years. And our biologic understanding, as Peter's outlined, has tremendously evolved, not only over the past decade, but just even over the past 3 to 4 years. And we're learning from these mistakes. I think our community in LM is so special. We talk to each other about these studies. We learn what we've done right, what we've done wrong, so that we can emulate those right pieces in other studies moving forward. So I want to keep that community in LMD moving forward. And I always have a slide about hope, which is usually a set of trials, but Dr. Forsythe perfectly outlined that. To me, these clinical trials are hope. And making sure we are building them correctly for success is a part of that. All right, so LM is, of course, understudied with inherent challenges, but we're moving in the right direction. We need a validated response measure as the foundation for LM studies. And there are newer diagnostic tools in novel clinical trials on the horizon, and that's my segue actually to Dr. Brenner. But I will also, in that segue, put in a plug. For tomorrow, there's an Advances in LM session, of which at least 3 of these things are going to be discussed. And so these are the 3 abstracts that will be discussed tomorrow, including some more data on CNSide.